something was wrong.
Yeah.
I really appreciate them saying.
Yeah.
Meeting yesterday.
Yeah, I figured that must be in that vicinity. Maybe Oregon, I don't know.
Know who they are.
I thought, please. I said it. It was a PDF.
Oh, I have.
Yeah,
Instead of a whole.
yes, a little clearer.
Talk to you about to the self-facility.
Switched it to that.
Oh, okay.
But it's the same, I saw the printout that you spoke of, it's the same stuff.
Well, Al, you found parking?
No.
How'd you luck out? It was terrible.
I'm probably gonna get a ticket.
I must have driven around 50 minutes. However, somebody pulled out finally.
Some of it is what the computer
And I'm here like it's in
It's like you need a spotter.
yeah. Well, I was here by like 6:30. I'm here
Yeah.
early trying to find a place.
Yeah.
I'll put up another.
So something if you can't find something.
Frank Smart, he just drove in the parking lot.
Jackie or
No, I was using the regular PAH. I'm worried about that on the head. Don't you, Alex? You have to have a sticker.
No, I mean, you just go to the desk.
was it like there was pretty.
I have to be there for like 5 days.
Oh, okay. So it'd be
Yeah, you just give that.
So the gate opens.
yeah, for some March.
Yeah.
Yeah, that was, right, at the end of March.
Parking under this building or the one across the street? Okay. And you just
I think
pay
you
it.
I
didn't
parked
know
over
it.
the other one, but
Oh, yeah.
then you just give it to them and they
And,
charge you $50.
Then the second part, you know, get busy again. But,
That I was gonna ask Len, I think
relatively,
probably we could
quiet. I
get
had a
a,
busy
like
month.
a
I think the
commuter
month of October.
ticket or something with a discount, like we used to, remember the S1 days?
Different geographic
Yeah,
We used to
right.
get a bunch of
That
those,
was.
and it was pretty cheap, it was like $5, that was a long time.
Quiet again.
Versus parking in the state.
remember, I was talking about now.
How about yourself?
Just not some too exotic. I mean, you got California,
Horse and very sorry.
Tucson's out there, and then you have. Well, we get the Western cities and Maui.
I
know.
You go to that all the time? That's nice one.
And I got to that until recently. That's what
yeah.
food like this.
I was,
I tell you what, usually the creamer is, you know.
Yeah, that's one too.
that's a nice one to get an invite to, though. I'd like to go again.
It's probably showtime here pretty soon.
Okay.
The
There's like
everything up and running. Yeah. I should probably get going because
Well, not anymore.
You are?
Finally,
No.
several reasons convinced
Oh, no kidding.
Bill to take it.
I'm already
All right.
putting it down.
Word of the day is Urticaria.
That expensive, but it adds up.
Well, you
Hello,
have to bring it over
everyone.
from-
It's my great pleasure to introduce my former mentor in training in allergy immunology, Alan Kaplan. Alan's had an incredibly distinguished career. Found out last night he was from this, I never heard of this town, but it's across from Midtown Manhattan, West New York, New Jersey. So as you'll soon appreciate, he's a true New Jerseyite. And he trained initially in rheumatology at the NIH with Henry Metzger. And then he trained with went up to Harvard with K. Frank Austin. And the Austin lab at that point was churning out most of the academic leaders in the U.S. and in Europe in allergy and immunology. And Alan's certainly one of the distinguished graduates of that program, where he became interested in the complement system and in the kinin system. So two incredibly complex biochemical pathways that I'm sure all of us have had struggles trying to capture the intricacies, especially the kinin system, since it's the interplay of inflammation, renal function, and the coagulation system. And one of those areas that he's done incredibly world-class research in these areas. He found founded the allergy training program at the NIH when he was recruited there after his fellowship training at Harvard. And I was one of the initial trainees in that program at NIH. He headed that for many years and then founded another rheumatology and allergy program at Stony Brook and later was chair of medicine there. And actually spent his longest period of time in Charleston for the last 2 decades at the Medical College of South Carolina, founding another training program in allergy and immunology. And today, as you'll be hearing, laid the groundwork for initial trials with omalizumab in chronic urticaria. And certainly it's been great service for the specialty as a whole. He's been prior president of the Quad AI and the World Allergy Organization. So certainly look forward to your talk, Alan, and welcome to Seattle.
Thank you. Thank you very much, Bill. It's a pleasure to be here. The talk today, as you can see, is going to focus on urticaria and the degree to which I mentioned angioedema will be when angioedema is associated with hives. So it's not going to be a complement-kinin talk so much as a mast cell autoantibody type talk, and the focus will be on what we now call chronic spontaneous urticaria, and what we know about it and how to go about treating it. My disclosures are simple, and it related to angioedema only involves Genentech, either as a speaker or I adjudicate allergic reactions to drugs that they are working on for various other diseases, most typically hypertension. And so during this talk, I'm going to describe some clinical features that distinguish chronic spontaneous urticaria from other types of hives. I'll briefly go through aspects of the pathogenesis and spend a good bit of time on the utility of omalizumab, and at the end, just a general approach to what you do with a new patient that seems to have chronic spontaneous urticaria in terms of treating them, whether they're simple and meaning responsive or a really tough one. This slide is a definition. Every once in a while, it's true, a group of allergists, it may be ridiculous, but there are a lot of people who think they know rash as well, and really every once in a while will confuse hives with some other kind of rash. If you ever hear somebody talk about an urticarial plaque, then you know they're not sure what they're talking about, and I'm sure you've heard the term. But the definition is that it's a wheal and flare reaction, of which I will show some typical photos. The reaction is at the level of small venules. So the histamine receptors and bradykinin receptors are on small venules, not capillaries. And that's where the leaf will occur, and they vasodilate, they increase permeability, and at least when histamine is the mediator, pruritus results, and that's because it stimulates type C afferent nerve endings that go through the spinal cord and then centrally up to the brain, and we perceive it as itch. Also, when these nerves are stimulated, there are neuropeptides that are secreted as a result of the stimulus. One of them is called substance P, and it magnifies the redness that you see, and that's called an axon reflex. And I'll show a photo of what we need there. So we use urticaria is an umbrella term because the number of different kinds are really quite large. I could probably rattle off maybe a dozen different types of urticaria that are pathogenically actually different. Using an old guideline, and we still do this, we divide it into acute and chronic. Acute being an individual whose hives are less than 6 weeks in duration, at least when they present to you, and chronic if it's greater than. 6 weeks. Needless to say, somebody who has new onset hives who walks in the door, you don't know which way it's going to go unless you have identified a particular kind of hive and you know the course that it takes. And when we refer to a process being chronic, we are also, besides the greater than 6 weeks, we're implying that they have hives at least most days of the week, if not every day. You will not see a guideline that tells you it should be once a week or twice a week or anything of that sort. Usually, when I use the term, I mean it at least 3 times a week, 3 days a week they're having urticaria. Because otherwise, I might use the word intermittent to actually describe what is going on. And then there are various subdivisions of it. So I'm going to begin, even though I'm going to focus on chronic spontaneous urticaria, I'm going to begin with a couple of physical urticarias that we'll go over quickly. And I'll mention a group of them, and everything that I will say about them as a group will be true, except for delayed pressure urticaria, which is in a separate category. But the first thing is the individual lesions last less than 2 hours. So it's a very good question to ask a patient when they come in, that if you took a pen, you had a typical hive, and you put a pen and put a circle around it, and then watched it and timed when it disappears. If it's under 2 hours, you've got a physical urticaria. That's like 98% accurate. And then there may be a particular physical stimulus, like an ice cube or exposure to cold for cold urticaria, exercise for cholinergic urticaria, and so on. The reason that it is a short-lasting hive is that if you biopsy it, there's nothing there. There is no late phase reaction in these kinds of hives, which is in contrast to so-called chronic spontaneous urticaria, which at first glance has a cellular infiltrate that might look like asthma if I didn't tell you what you were looking at, except for the fact that it's the skin. And most of these physical urticarias will respond to high-dose antihistamines. There is a converse to that, and I do have it there. Keep this in mind, that cold urticaria, as an example, or dermatographism, as an example, will not respond to corticosteroid. And the reason, there are two parts to the reason why that is so. One is that steroids do not inhibit histamine release from cutaneous mast cells. Number two, there is no cellular infiltrate, and that's what steroids tend to work on. Because all of the steroid-responsive hives, whether I recommend steroids or not, this is theoretical, if there's a cellular infiltrate, they're going to respond to steroid. If there's no cellular infiltrate, they will not. And you have to move on to other approaches. But these, the first choice is going to be antihistamines. So here is a patient where you put an X on the skin because you think it's a dermatographism, and sure enough, there is a prominent wheal. And the redness in this slide may not be all that visible. It's right along the edges of the wheal. So what you are seeing is vasodilatation and increased permeability, such that the interstitial fluid leaks out exactly where you stimulated it by putting an X. You could use a tongue blade, for example, to do that. If you watch that hive, it's going to be gone in about 30 minutes. If you biopsy it at any point in time, the only thing you will see is that there seems to be fluid in there. The collagen bundles will separate, but there will be no cellular infiltrate. And it will be gone. When it's gone, and there's no sequela. There's no aftermath or later reaction that you see. Here is a photo of somebody with cholinergic urticaria. This person was put on a treadmill because they had exercise-induced hives. They begin to, as they're exercising and heating up, they start to itch after a few minutes, and in about 10 minutes, they break out like this. Of course, I'm showing you one of my best shots, but these are typical cholinergic hives, which tend to be small punctate hives that begin centrally. Neck, upper chest, and back is where it starts, and then it spreads out distally, peripherally, if they keep exercising. But if they stop exercising, and you would stop after 10 minutes of exercise like this, and sit down and cool off, within about an hour, it's gone. And like the other, no late phase, will not respond to steroids, can't prophylactic with steroids, and it's so fast you couldn't treat it. The only way to treat it with antihistamines is prophylaxis. You would have to be on some antihistamine perhaps 3 or 4 times a day to stop this. So in cholinergic hives, I already said where they sort of begin and spread. The things that trigger it are exercise, usually to the point of sweating, hot showers, occasionally strong emotion. This point worth noting here is the fact that certainly among the public, they think you can get hives by being stressed. Right? A lot of people believe that. Some physicians do. It's totally false. You absolutely cannot make hives by being stressed, and whether you can worsen hives if you already have them by being stressed is highly debatable. My own take on it is that the stressed individual tolerates them less well, so they complain more. But this one is an exception. Because of the pathophysiology of this hive, when they're stressed, you can bring out a hive. And I've done it, a curious one. I had a few patients with cholinergic urticaria who were afraid of needles, and when I went to draw blood, they broke out. And and it's reasonably reproducible. If they're quiet and you put them on a treadmill, you will bring out the hive. And you saw the picture of the lesions. Once in a while, if they become confluent, like on the face, it could look like angioedema. And it is caused by histamine release into the circulation. So here is an old slide. It actually was done at NIH when Bill was there. But we will get to more modern times. This is a blood histamine level. It's one of the first ones that was ever done. Over time, in a patient with cholinergic urticaria who we exercise, and it's just 3 of them superimposed. And you could see the similar time course, right? It starts very low, and while they're beginning to itch and starting to break out, that's where the upswing is. And then we had them quiet down, and it gradually comes down and returns to their baseline within about an hour. So you could see the histamine release, and that's why antihistamines work. So I'll switch to cold urticaria for a moment. This is cold contact urticaria. That's why the ice cube test works. A typical patient, if they're dressed, go walk out on a winter's day when the wind is blowing on their face. If they're not wearing gloves, those are the areas that are exposed that would be the first to break out. This is one of the few hives that can be associated with anaphylactic-like symptoms, but that's usually associated with swimming because the water will be different from the ambient temperature. The person jumps into the water, bobs up and down a few times, and the temperature change is what brings out the hive. And of course, the intensity of it is proportional to the surface area of skin that's exposed. So this one is like total body, and the histamine level can go up so high that it goes from the venous side of the circulation to the arterial side of the circulation. Transiently, the person becomes hypotensive, passes out in the water, and drowns. So that's why this particular type of urticaria, when it's really severe, is potentially fatal if the individual goes swimming. Now, that one is a really good slide having to do with the wheel and flare reaction and all aspects of it. An ice cube was placed on this cold urticaria patient. It was then removed. When the ice cube is on it, it turns red and feels cold. But it's when the skin warms after being chilled that the histamine comes out. So you can see the wheel. You can see where the ice cube melted and trickled down the person's arm. And there is the flare, the axon reflex that makes it so red surrounding it. When the histamine is released, as it spreads out, you are vasodilating, right? Wherever the histamine, as it's diffusing, the concentration is getting lower and lower as you go out to the periphery. But then you stimulate the nerve endings that release the substance P, and that's a reflex. And then in 2 seconds, the redness goes from here to there. And that's what you're seeing there as the axon reflex. So that's all the manifestations of what histamine does when you, even if you just injected it into skin, when you use a positive control for your skin test, this is what's happening. And if you, instead of putting an ice cube on the person's arm, take one of the hands and plunk it in a bucket of cold water for 5 minutes, and then remove the hand from the cold water, the hand starts to itch and begins to swell. And the point of this slide is you could not properly say whether that's urticaria or angioedema. I think most of you would say this is angioedema of the hand. So the point I'm making there is here's an example of where pathogenically urticaria and angioedema can have the same pathogenesis. The only difference between the two is the level of the skin at which the reaction is occurring. So urticaria is superficial. It involves the venules in the superficial dermis. Angioedema is in the deep dermis and subcutaneous tissue. So this is, quote, cold urticaria, but it's cold-induced angioedema when you do it this way. When you have angioedema in chronic spontaneous urticaria, which we'll get to in a little while, the same is true. It's the pathogenesis is the same. They're just having the same reaction occurring deeper in the tissue. If we switched topics and talked about like hereditary angioedema, where it's bradykinin mediated, you get angioedema with no hives. Now the pathogenesis is like totally different lecture, different approach. So this is cold-induced angioedema. What you can do, because now the hand is swelling right before your eyes within a period of 5 minutes, it's really dramatic. You could take a catheter and put it in the brachial vein, draining that arm, and now you could also measure histamine, just as I showed you with the cholinergic urticaria. This is one of the first patients also ever done, and it's very illustrative, which is why I'm repeating it. And you could see the baseline here, and then at -4 is where the hand was put in the cold water. At 0 time, it was removed, and you could see the dramatic rise in histamine while the person's arm was swelling, and you could see that it's all over within about 20 minutes. Now, of course, when you swell, it takes a day or two for that, or at least many hours. That violates my 2-hour thing. That's only for urticaria. If you make angioedema with it, there's only so fast that the fluid can recede and the swelling go away. So that takes a long time. The vertical lines that you're following is this person's systolic and diastolic blood pressure while that was happening. I think it's perfectly obvious that the blood pressure dropped right where the peak of the histamine is, and then gradually rose again. When that happened, which was right before our eyes, done in the lab, our blood pressure rose because we didn't know how far that was going to go. But you could just imagine what would happen to that person if they just jump into a pool of water that's not at ambient temperature. This is to show that you could take skin outside the body of the patient and do the same thing. So we did skin biopsies on cold urticaria patients, and small biopsy, you could put it in phosphate buffered saline, say at 4 degrees, and keep it there, or at 37 degrees and keep it there, or put it at 4 degrees for 5 minutes and then raise the temperature to 37. And then you see the histamine release in 2 separate patients. Patient 1, and if you change the temperature, or patient 2. That demonstrated that if you cut all the nerve endings, because there was a theory way back when that some of these physical urticarias, cholinergic notwithstanding, that you required some kind of nerve interaction with mast cells to make a hive. Well, there's no nerves there. It's all cut when you do the little biopsy, and you show that you could reproduce this in this way. Now, the next step, which brings us towards the next part of the talk, is this kind of urticaria is passively transferable. It's in the pre-AIDS era, but you could take the serum of a patient, inject it to do an intradermal skin test in my skin, wait 2 days, put an ice cube on the spot and make a hive. Now, my mast cells are normal, but the serum is transferring something that would make my mast cells cold sensitive and release histamine. And that substance turned out to be IgE. So think of it for a moment. It's true not only of cold but some other physical urticarias, that you've got a kind of hive that you could transfer with IgE and make more normal mast cells become abnormal in a particular way. Okay? There's no antigen. The physicals, have some kind of a physical stimulus. Our first thought on this, especially in the cold urticaria, is that we had an IgE-dependent cryoglobulin. If you can picture IgE aggregating when you chilled it, aggregation is what antigen does. And then aggregated IgE, when it binds to mast cells, would cross-link the IgE receptor and they would become activated. And then when you warm it after being chilled, because cold mast cells don't like to secrete, when you warm it, they fire. Well, during the same article, we proved that the transferable IgE is monomeric. So that went out the window. It's monomeric IgE, which is an antibody to nothing that we can identify, that makes a normal mast cell become abnormal. Keep that in mind when we talk about omalizumab and our theories in chronic spontaneous urticaria as to the direction in which some of the ideas are going. So I'm going to switch for a moment to antihistamines for a moment, because all the main therapy for physical urticarias is antihistamines, right? And what they do is block H1 receptors on vascular endothelial cells, which again is concentrated along small venules, which is where histamine binds. And they inhibit vasodilatation and the permeability of the itch and diminishes the axon reflex. Axon reflex never goes down to 0, but close. Part C is the most important point. And all antihistamines are reversible binders to the histamine receptor. So if I have this amount of histamine and that amount of antihistamine, histamine will win. It's a competitive equilibrium of a sort. Therefore, if you're going to block histamine, your antihistamine concentration has to be quite a bit greater than the histamine concentration is locally. Which is why for many of these, if you take your favorite non-sedating antihistamine and give the patient one a day, I will bet against you. 80% of the time it won't work for these physical urticarias. They need to take 3 or 4 a day in order to get a dose that really is effective. And let me just add a theoretical point on the histamine-antihistamine equilibrium, because it's not exactly competitive. What happens is there is a histamine receptor, and the equilibrium is the conformation of the receptor. When histamine hits it, it's active. When antihistamine hits it, it flips over and it's inactive. So it's which way you flip the histamine receptor, but it's still proportional to the ratio of antihistamine to histamine. And you want the antihistamine to win if you're going to be effective in treating the patient. So here's a patient whose hives look a little bit different. And this one you wouldn't really like to have. This is what we mean by chronic spontaneous urticaria, picking out one of the worst cases I had to take a photo of. There can be a small number of hives. You could be covered with the hives. 40% have angioedema associated with it. When the angioedema occurs, it's in the typical places, sometimes hands, sometimes feet, sometimes genitals, often lip. Periorbital is common. Face swelling, maybe half the face would swell. Tongue swelling is not so common, but can occur. Pharyngeal swelling is rare, but I've seen soft palate swelling with uvulas dripping down. But laryngeal edema never occurs. So if you have a patient with this that you think has laryngeal edema, think what other diagnosis this might be. So I, who've been doing this for 40, 50 years, do not give EpiPens as a rule to patients with chronic urticaria. I make some exceptions for some related angioedema things, but the exception that I'm doing is just to slow the course to make the patient more comfortable. But I've had too many patients come to me who were told that the angioedema that they have with this disease is potentially fatal, and therefore they have to have their EpiPen with them all the time, and therefore they walk around feeling like they're a walking time bomb. And the best thing I could offer those patients before I got into therapy or whatnot was a garbage can I used to have next to my desk, and I had them take their EpiPen and just dump it and insist that they will never use it again. And talking about relief of stress, that was step number one and was exceedingly effective. So bear in mind that it is not like HAE or an ACE inhibitor angioedema, which are potentially fatal, no matter how bad the hives happen to look. So angioedema in those patients occur in 40%. In the literature, it's up 40 to 80%. I'm sure 40 is about the right figure. Some of the chronic spontaneous urticarias have associated physical urticarias in addition. The two most common would be dermatographism, the one I showed you the photo of. You should always check for dermatographism by scratching the patient. But some of them have this delayed pressure urticaria, which is a physical urticaria that I said was the one exception to everything that I said about physical urticarias preceding it. If you had a patient with pure delayed pressure urticaria, the histamine would be something like if I hammer something and have a lot of pressure on my hand, about 4 hours later it may start to itch and swell, and it will swell up, it will be symptomatic for hours later and then finally go down. That's why it's delayed in onset, and it's very different, and it has a cellular infiltrate that looks like chronic spontaneous urticaria. So delayed pressure is different and often occurs concomitantly with hives that are spontaneous, meaning the person could go to bed being perfectly clear and wake up covered with hives the next morning, having no clue as to what had happened. And that's why this says ordinary urticaria, but I like the term chronic spontaneous rather than idiopathic, because idiopathic, suggests we don't know anything, and spontaneous is how it feels to the patient. It also allows you to insist that it really is spontaneous, and therefore they should not be spending their time looking for exogenous things that cause the urticaria, like foods. And we do not do food skin testing as a routine in our chronic spontaneous urticaria patients. Some insist that you do it, and then you sort of pray that nothing comes positive, so you have to explain it. But in general, that is the approach. Thyroid disease, or at least thyroid antibodies, are present significantly. It's about 20 to 25%, and some patients have Hashimoto's thyroiditis. I mean, they ended up on thyroid hormone because they are hypothyroid, high T4, low TSH. I think I said it backwards. Hypothyroid, low T4, high TSH. And that occasionally occurs. And the fact that these antibodies are present was the first clue that maybe this disease could be, at least in part, be autoimmune. I mean, 25% is substantial. And it really was a close association with at least the thyroid antibodies, even if the person was clinically euthyroid. And Lesnov, on that first article, was the first one to demonstrate that was in fact so. And when we took a look at it early on, we're still talking now, we're only up to 1999, but this was quite a few patients in this, and antithyroglobulin antibody was present 8%, antimicrosomal 5%, both antibodies 14%, and in total, one or both, almost a quarter of patients, some of which had an abnormal TSH to go with it. We know in more recent literature and our own stuff that what's a little bit aberrant in this is the incidence of antimicrosomal antibodies is higher than antithyroglobulin in general, but it wasn't in that particular study. but about a quarter of the patients have these antibodies. And so here is a skin biopsy of such a patient. The point of this biopsy is to show a small venule in the skin there, a cellular infiltrate that is perivascular. If you examine this infiltrate carefully and use special staining to see what's there, most of the cells you are looking at are lymphocytes. We know most of them are CD4s rather than CD8s. That is a mixture of Th1 and Th2, but Th2 is probably predominates, but not as skewed as it is in typical allergic reactions. There are some neutrophils. Eosinophils vary. Sometimes they're low, sometimes they're very prominent. Basophils are always there, but you need special staining to see them. So all the cellular elements are in there, with the exception of one. There are no B lymphocytes. All the lymphocytes are T. So even if autoantibodies are being made, it's not happening in the skin. There's no B cells, no plasma cells. It's happening more sort of systemically, and the antibody ends up in the circulation where it could diffuse into the skin, but it's unlikely to be made there. Another point is that the integrity of that vessel is normal. This is not vasculitis. So it is a perivascular, non-necrotizing infiltration with cells, which lasts a few days on an individual lesion and then goes away, presumably. So when you see a lesion like that, if you had a box to check, responsive to steroid or not responsive to steroid, you check the yes box. And you all know, although we're not using them chronically to treat patients, most patients will respond to a dose or two of steroid and feel an awful lot better. So that's a big difference from the physical urticarias. Also, what's the response rate of this to high-dose antihistamines, which most of us use first? Anybody want to venture a guess? Pick a number. No takers? It's not much more than 50%. It's 40 to 50% will respond, and you won't need anything beyond it. But it's not more than that. For the physical urticarias, it's like 85%. So physical urticarias are clearly antihistamine responsive, and then you have the non-responders are tough, and we'll talk about it briefly. But to say that chronic spontaneous urticaria is a histamine-responsive disease in a blanket statement, well, it's not more than about 50-50. I could argue that if the real number was 45%, then I would vote that it's not responsive to antihistamines. Okay? So keep that in mind, that antihistamines come first, but we kind of exaggerate what's going to happen when you use them, including the guidelines. I went through this in terms of what the biopsy shows. So here's a cartoon-like thing showing you, let's say, a cutaneous, a mast cell that presumed is a skin mast cell. And the little yellow circles are IgE receptors. And I put IgE on many of the receptors, but not all. Notice the ones on the right-hand side have no IgE on it, where I have the green arrow. And we now know, this was Malcolm Greaves who found this originally, and that was a New England Journal article in the 90s, that about 40% of patients have an IgG antibody that reacts with the IgE receptor. And it preferentially reacts with receptors that do not have IgE on them. We all have unoccupied receptors in the skin. So here's two receptors, unoccupied, cross-linked by the IgE. So that's like what antigen does. Antigen indirectly cross-links receptors by binding to two adjacent IgE molecules. So we cross-link the receptor, the cell secretes, you get a cellular infiltrate, that's what I mean by a late phase-like reaction, and you get a hive that is infiltrative. I'm not going to go back to that photo, but you could see that was an indurated kind of hive in chronic urticaria. When the patient puts a pen circle around that and you ask how long does it last, it will always be greater than 4 hours. And usually 10 hours, 12 hours, and it finally fades out. Okay? Maybe 24 would be up to like an upper limit. Remember, most physicals are under 2 hours. So that when in doubt, that little trick, and sometimes there is doubt, that little trick is a good one to sort of characterize patients if it's not obvious just by looking. And so if we say that a subpopulation of patients are associated with autoimmunity, we've got 40% anti-receptor antibody. There's another 5% that's anti-IgE itself. Let me just go back for a second. If I took those two green arrows and cross-linked the two red IgEs, which is what antigen does, you'd get the same result. And 5% have anti-IgE, and 35 to 40% have anti-receptor antibody. And they are functionally indistinguishable, so you have to do something to make the distinction. So here's a couple of hundred patients with chronic spontaneous urticaria, and we try to see which ones have the anti-receptor antibody. The easiest way to do that is to draw blood from a person, normal, volunteer, and get their basophils. Those basophils are easier to get than mast cells, and you add the serum of the patient to them, and if they have this antibody, it cross-links the receptor, and they fire and release histamine. That's what you're seeing here. So there's the autoimmune group. Our cutoff was 15% histamine release, which was we use as a background that makes it obvious so that you don't add false positives to it. So we exclude these as being negative, and this is the obviously positive group who have autoantibodies. Many, but not all, of these also have the antithyroid antibodies. They also have antibody to, they also give you a positive ANA. The incidence of a positive ANA in chronic spontaneous urticaria is around 30-35%. It will usually be low titer. It will be a speckled pattern. If you do anti-double-stranded DNA, which is specific for lupus, it will be negative. And my advice is not to do the test, because you'll turn up a bunch of positives, worry everybody that they have a connective tissue disease, and end up doing 8 different assays for all sorts of lupus antibodies, and invariably they will be negative. Person comes in with arthritis with their hives, or a lupus rash, or something, or proteinuria, that's a different story, then you go after it. But the typical patient, don't draw that one. Remember I said that it's preferentially unoccupied receptors that the antibody acts on. Here are 4 patients and a control. And this is the basophil histamine release. So look at these 4 patients. This is super positive, weakly positive, in between, and a negative control. That's the histamine release of 4 patients like the ones I showed you. If I take a myeloma protein, so that's it's milligrams of IgE, and add it to the basophils in my assay, now I saturate all the receptors. And you repeat the assay, you get the purple. It won't fire. So that demonstrates that it's unoccupied receptors that are reacting to the antibody. And this one shows that actually a complement has a role, but an augmenting role. Here is individual patients. What we did was the following. The anti-receptor antibody, remember, is IgG anti-receptor antibody. So we purified the IgG antibody. So now we're not using serum. We're using IgG. And you could add IgG to the basophils, and they will fire if the IgG is from, if it's an anti-receptor antibody. So we took the one that works, and we serially diluted. So that's in the pink here. So here it looks like 25% histamine release. So this is undiluted 1 to 2, 1 to 4, 1, and so on down. This is the IgG of someone who doesn't have hives. So that's our negative control. Now we took this patient's purified IgG and added it to normal serum. So normal serum has got nothing that would activate the cell. And you add it to normal serum and you go up this curve. So there is a big augmentation. This last one is serum-free. In other words, it goes back down. That's just the pure IgG. So if you put hatch mark up there, that is that augmentation. So there's something in serum that augmented the reaction. Okay? So you take pure IgG from the patient, add it to normal serum, and it goes up. Now you take serum from a patient who's congenitally deficient in C2, and it doesn't work. That's the classical complement pathway. So you know you're activating the classical complement pathway. So then you ask, well, what in complement activates basophils? And it's C3a or C5a. So now you do it, and you get serum that has no C5. So you now go through 1, 4, 2, 3, but you come to 5, it won't go further. C5 won't work. Now it makes you suspicious that C5a is the culprit. Then you go back to the normal serum, do this augmentation reaction, and add an antibody that blocks the C5a receptor. And it goes back down to where the red line is. Okay? So you are making an immune complex when you add anti-receptor antibody to the receptor, makes an immune complex, fixes complement, goes all the way to C5a. The C5a hits the C5a receptor and augments the reaction. That is shown on this slide. Here is a cutaneous mast cell. Here is our antibody to the, in blue now, is the IgE receptor. IgG, anti-IgE receptor. So the receptor is the antigen. So here's the two FABs binding the antigen, and the FC sticks out here. Now the reason I put 1, 2, 3, 4 receptors together, which binds two IgG molecules, because to fix complement, you need two FCs sticking out, which means you have to get 4 receptors in tandem to do that. And now you make the immune complex, and you go up there, activate C1, cleave 4 and 2, you make the 4B2A enzyme, cleave C3, the C3B attaches, makes the bigger enzyme in purple, cleave C5, releases C5A, hits the C5A receptor, and now you have the full reaction. So you activate the cell, and you release everything the cell is capable of releasing. I will add here, we'll come back to that later, just because that releases leukotrienes, you all know that all mast cells release leukotrienes. That does not mean that leukotriene is making the hive, right? You'd have to use an anti-leukotriene or leukotriene antagonist, shows that you improve the hives. Okay, we're coming down to how I would sort of treat hives in a modern way. And I'm certainly going to put some emphasis on omalizumab. But I'm actually beginning here with just a couple of slides on cyclosporin to make a few points. First of all, it was discovered first as being a good drug for hives. I was using it for a number of years before we came on the omalizumab story. I'm a therapeutic nihilist. I do not believe most of the therapy literature that I read, particularly if it involves hives, and I'm almost, if you want to be right, say that the article that says this new drug is wonderful, assume it's wrong. And you'll be right 90% of the time, because our success rate has been bad. Okay, and I'm going to tell you why also. But cyclosporin was touted too. It's very good, and even in severe cases. There was double-blind, placebo-controlled studies. It focused a bit on the autoimmune group, but it works to a degree in everybody. But what's the problem with cyclosporin is it has toxicities, hypertension, you have to watch blood pressure, and you have to watch kidney function. The doses touted for this, and this would be an adult dose, not based on weight, is low compared to the way the drug is used as an immunosuppressant, like for a kidney transplant. So its effectiveness is like 65–70%. And cyclosporin does something that no other immunosuppressive drug does. All the immunosuppressives are working on T cells, right? T cells, sometimes monocytes, but in the lymphocyte, monocyte, you don't think of immunosuppressives working on eosinophils or basophils. Cyclosporin is the only one that inhibits basophil histamine release and mast cell histamine release. And here is a slide that shows with increasing cyclosporin concentration, this is percent inhibition of histamine release, done in vitro. And you could show as the cyclosporin goes up, the histamine release goes down. This one is a little different because the stimulus for the histamine release is a patient's IgG anti-receptor antibody. And it's done in vitro with the assay that I showed you. And we start with infinitesimally low cyclosporin levels. And we go up, 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 and then we hit a threshold. And suddenly it inhibits. And this level is achievable in plasma in the doses that I mentioned to you. So it specifically works on the antibody in question. So keep in the back of your mind that cyclosporin is a good drug for chronic spontaneous urticaria with a success rate of 65–70%, but you have to be careful in using it. But then, now we go back, this is 2008. And this study, and I was working on the things that I'm talking about here, and I was thinking that maybe autoimmunity is important, and maybe this IgG anti-receptor antibody is pathogenic, at least in some people. So knowing what omalizumab does, which is to bind IgE in the circulation, and it drops it close to zero. It's touted not to bind to IgE on the surface of basophils and mast cells. If it did, it would activate the cells. So, but we know when IgE goes down, you secondarily downregulate IgE receptor. And the receptor is the antigen. And if remember I showed you on multiple slides that you need to cross-link 2 receptors at least that are close together, and maybe 4 if you activate complement. But if, let's say, you downregulate them and the receptors are more like this, then you could bind them individually, but you cannot cross-link. And if you don't cross-link, you will not activate. So the thesis was that if you used omalizumab and downregulated IgE receptors, you should make the hives better. And that's where we started our what you might call a phase 1. It really was not. It's not a real phase 1 because it's in the market for asthma. You don't need a phase 1. You need a proof of concept. Is there any chance of this working? And that's what we did. That's the paper in 2008. And we did 12 patients, and they were all in the autoimmune group, and really severe. And many of them also had the antithyroid antibodies. And it's 12 patients. It was single blind. And this is the most important one. At the end of the 20 weeks, 7 out of 12 had no hives. 4 more, which would make 11, even though that looks sort of you can't really tell that anything dramatic happened like these. But these patients were much better. They were allowed to take antihistamine ad lib up to 4 times a day. And they all stopped their antihistamine. So they were like 50 to 75% improved. And one patient there was a failure who had come to me on high-dose steroids and ended up on cyclosporin. And that was a good enough result to have a phase 2 study of 80 patients in which Saini from Hopkins was the lead and got the same result we did, but in 80 patients, and it looked good, and then it moved on to phase 3, of which there are 3 studies, 2 of which I'm showing here. Asteria 2 was in the New England Journal in 2003, and Glacial, not impressive, I have to update the slide, it came out a year later in the JACI. And they differ, this has the 3 studies, but they differ slightly. But the One is 12 weeks, one is 24 weeks, and then so the total length, then there's a follow-up period. This one had 3 doses, and by the time we did glacial, we settled on the 300 milligram dose. These patients failed H1 antihistamines. These patients failed H1, H2, and leukotriene antagonists. And this is the result of the Asteria 2 New England Journal patients. The two sides really show the same thing in a different way. Let's focus on the right. The first thing to look at is, in gray, is the placebo response. So the placebo response there is about 25%. You'll see that again in almost every good study on chronic spontaneous urticaria. The placebo response is about 25, sometimes even 30%. It's important to bear in mind, because when you study some other drug, dapsones, hydroxychloroquine, if there is not a response that significantly exceeds 30%, don't use it. I mean, that would be my conclusion in the study. Also, if you take 300 patients and 80 of them respond, and you interview that 80 for television, everybody will think that that drug is wonderful, which is what they do all the time. So the placebo response here is one of the most important things in this slide. Then you'll notice in red, 75 milligrams was a little bit better, but didn't reach statistical significance if you look on the left. At 150 made it, and 300 is looking mighty good. And you notice in this study, when you stopped after 12 weeks, the patients got worse again as a group. Not every single patient, a few just stopped their hearts. But most of them as a group went back. Notice that they went back to the placebo level, right? They didn't go back to the level that they began with. Now we looked for people who responded particularly well, or totally. Particularly well as a UAS 7, you know the scoring system, the maximum is 42. And if they were less than 6 over a week, that's a very good response. And in this study, at 300, it was 66% achieved that, and 44% had no odds whatsoever. They had a UAS of 0. That's a huge number in terms of having nothing. The glacial study came next. That's a longer study, 24 weeks instead of 12 weeks. And they failed H1, H2, and leukotriene antagonists before they went into the study. There's no dose response. We were using the 300. The results are even more striking in this study. Again, notice the very nice placebo response and the more dramatic response with omalizumab. So there's like no comparison. It's perfectly obvious that it works. And you stop after 24 weeks, that's 6 months, and when you stop it, most of the patients go back to their placebo level. So that's not long enough as a group, even though it's approved for 6 months at a time. You're going to find yourself, repeating that. And there are studies that now show that if you stop the drug and the patients get worse, and then you restart the drug, you get the same response in general. So patients' responsiveness stays. We do not know how long you need to be on the drug to have a patient, get off the drug and tell you, oh, gee, it's better, and it seems not to be coming back. If you go long enough, there's a dropout rate, right, in terms of patients spontaneously remitting. That would be the control for that. I would say in 2 to 3 years, almost half the patients, if they don't remit completely, get better in 2 to 3. Once you get beyond that, it could be 5 years, it could be 10 years, and there are no good statistics on it. But patients can have it a very long time. Interesting, those two are almost superimposable. One is UAS 7 and one is an itch score. That's the weekly itch score. And that's the hive score. And you can see they're almost superimposable. And this study, the super good responders were a little less than the other, 52%, and as was the UAS 70, 33%. But in general, when you take the aggregate of all the studies that are out there, and there are a lot of them now, I would say 40% is a good round figure for the total responders, and it's up around 65-70% for people who are markedly improved, and that may even be conservative. So, now, I have not shown anything on response rate, but we know there are some patients who respond in a couple of days. So it acts so fast that downregulating the IgE receptor can't be the answer. Others respond gradually in 6 to 8 weeks. There, you do downregulate the IgE receptors. I want to focus in this one on item number 2. It's a new article, came out in the last year or two, that demonstrated that there is dissociation of the IgE from the surface of mast cells and basophils when you use omalizumab. If this is right, and if IgE bound to the cell is important for cell function in general, that dissociating an IgE, so you just have free IgE receptors, and then downregulating the receptors, may be sort of a non-specific omalizumab effect that occurs first before you later downregulate. So I'm thinking that there is a non-specific desensitization of skin mast cells in particular with omalizumab that might explain the fast responders and then everything we've been talking about, the more delayed responders. Then you downregulate the receptors. There's a reminder that IgE receptors are not just on basophils and mast cells, but other cells. And everybody has always wondered, is there an IgE to an autoantigen? Make believe there was a skin antigen to which they are really allergic, and you're just taking away their IgE. Nobody has ever found this. It's a theory that I don't really think I buy, but it's not formally disproven. And so, in terms of the treatment of this disease, new guidelines are coming out that are going to mirror this, but I can't show the new guideline. But I published this a year ago, and it was my idea based on what I knew at that point in time. And I put approaches to consider when antihistamines fail. And in short, I only recommend 2 things. I would use omalizumab next. When that fails, I would use cyclosporin. I would not use, of course, steroid chronically. You can use it in short bursts for something acute. I no longer would use an H2 antagonist. I will not use a leukotriene antagonist. I did it for decades, and I thought I was wasting my time, and it turns out I was. And all those ones in the middle, there's all sorts of literature on that. These are not better than placebo. These are falling within. There's no double-blind placebo-controlled studies that are believable. When there's a study that looks believable, you'll notice that they have a placebo of 8%, so that 15% looks good, and you know that's wrong. Of course, it's 30%. They were all felt to be somewhat effective in urticaria vasculitis. And everybody presumed that because it acts on vasculitis, that some of them are really good, that it's going to work on chronic spontaneous urticaria. And that's just false thinking. They're completely different diseases. And so I don't think any of them are any good, and I personally don't use them. And then I did a little calculation to finish up with, knowing the response rate. If a group of patients respond to antihistamines, you'll treat 45% of them. If you take the non-responders, that's what's 55%, and you do omalizumab, you will at least treat 65% of those. If you take those failures and treat them with cyclosporin, you treat about another 65-70%, and I calculate that would treat about 93% of patients, and I think those numbers are conservative. So I'll leave you with that chronic urticaria should not be such a tough disease to treat because we've got good drugs that really works. And if those of you who have experience with it, omalizumab has absolutely changed the course of that. In some respects, this disease, in terms of success rate, is just as easy, if not easier, to treat than asthma, which was, if I said that 15 years ago, you'd think I was completely nuts. And so it has changed dramatically, and work goes on. We still don't understand a lot about it pathogenically. We know people who don't have the autoantibody do respond, so that's part of the answer, but far from the whole answer. We're still not understanding the super fast responders, although I locked on to one possible explanation that caught my eye in the literature. So we're still trying to figure out how it works, and of course, in the future, better drugs yet may appear that will go even further in terms of our success rate in treating this disease. Thank you. Yeah.
What are your thoughts or your experience with tacrolimus as opposed to cyclosporin?
Tacrolimus I have good experience with. I have used it as an alternative on occasion, just to do something different, and its mechanism is strikingly similar, so that would be the only exception. But I have experience with methotrexate, azathioprine, mofetil. None of those will do it.
Do you find that tacrolimus is easier for the patient to tolerate? That's sort of the data out of UT Southwestern.
It's really immaterial. Yeah. I know that its effects on renal function are a little bit less. Yeah. So, but I wouldn't substitute it because there's no data. Right. That's my personal experience. I've used it a few times successfully, and I believe it could be good.
Do you find the endocrinologists believe you when you say that autoimmune thyroiditis is associated with urticaria? Because my endocrinologists say that that's not a link.
Yeah. Oh, that it's not associated with urticaria.
They say there's no data, and then I'm looking at you and there's data.
Yeah. But what he probably does is, if your patient population is Hashimoto's thyroiditis, how many of them have hives? Well, it's so low he may not see any. Our patient population walks in with hives. He doesn't see those. If you have hives, 25% have the autoantibodies. Okay. So it's a different population.
That's my argument.
Yep.
Thank you.
Sure. Yeah.
Because significant number of patients do not respond to antihistamines, so how high would you go on antihistamines if somebody is not responding?
In this day and age, I think it's reasonable to the 4 a day. Pick one, cetirizine or whatever. When I say fail it, I mean have no response. Right? If you do 4 a day and nothing happened, they failed. Move on. If I had a patient where I was really confident, they're still having some hives, but they are responding, like they're 50 to 75% better. Would I go higher? Yeah, but it's not in the guidelines. Well, before the new antihistamines, I go back a long time, and I was using hydroxyzine, Atarax, or Benadryl, and they're all so sedating, and all the literature says that you're going to make everybody sleepy, and they're going to crash their car, and the kids won't do well in school. I don't believe a word of it. And we used it for years. And the maximum dose was 54 times a day for hydroxyzine, which is 6 cetirizines a day. So that would be the maximum in my experience that I have ever used. But in this gray zone, nobody knows anymore. And it's changed. Omalizumab is too easy. If you're not happy with the response and the patient is not smiling, switch.
Do you use ketotifen at all?
Huh?
Do you use ketotifen at all?
No, and don't. That is just a fancy antihistamine that you can get. You may get it easy. I used to get it from Canada. Yeah, it does nothing different than an Atarax.
Okay.
Anything different about? We've had a couple of patients with CVID with urticaria, and got one patient under
common variable immunodeficiency.
Yeah. Anything different about that? I mean, the patients come under control with high dose omalizumab. We had to increase it to twice a month.
I have not had immunodeficient patients with hives, so I don't have an experience with it. I don't know. With nothing unusual, if you only looked at it from a high point of view, it looked like
Yeah, so
ordinary.
combination of IVIG plus omalizumab is.
Yeah, considering they're immunodeficient, it would be interesting to get all the antibodies on them and see if they turn up positive or negative. You would think, oh, well, if they're immunodeficient, they ought to be negative, which would be, I guess, logical. But, there are some disorders like Hodgkin's disease, to name one, where you have a kind of a lymphoma where sometimes it's associated with immunodeficiency, except their IgE levels tend to be sky high. So there are exceptions. So it would be worth taking a look out of curiosity, but I don't know if they're different.
And another question is, how long do you think you could, for some of the studies coming out of increasing the dosing regimen of omalizumab to keep them under control?
All sorts of people have experienced doing that on difficult patients, sometimes working, but increasing the frequency, 300 every 3 weeks instead of 4 weeks, going up to 450, even 600 on a small number of patients, but no studies yet. I can tell you sort of from the grapevine that some patients are responding to the higher doses. We have a small number of patients that we've treated with a combination of cyclosporin and omalizumab. But you're getting into really extreme groups.
And have you tried any with some of the new eosinophil therapies?
I have not.
Do you have
There
that
are all sorts of things coming down the pipe. The cytokine antagonists, and IL-5 antagonists, maybe even a C5, maybe a complement antagonist. You'll have to try them to see. I don't think any of them hit something quite as fundamental as omalizumab does, though. At least for this disease. Yeah.
How do you approach the duration of therapy for omalizumab? Like, if it's working, how long do you trial off, or do you space the dosing? What's your approach?
I know that the insurance companies dictate that to a certain degree, right, as to how long they will allow you. Somebody was mentioning to me that some companies require failing leukotriene antagonists, for example, before they will allow it. But as soon as the new guideline comes out, not recommending that will change. And so I can't answer you. If I could do it myself and do it, any way that I want, I surely wouldn't stop before a year. And I really think if you could go 2 years and stop, there'll be a lot of dropout. In other words, I think after 2 years, only a fraction of the patients are going to rebound on you. I think it would make a difference there. Now, you could argue, though, but that's excessive and it's using, spending a lot of money and so on. That's why the study that showed that I think is important is that if you stop at any point and it doesn't work out, you can restart it and get back where you were. So that's important. But I think for a sustained therapy in this disease, if you had to pick a time limit when to stop and see what's happening, I would pick 2 years.
We've often had patients taper, so they do a year of
now,
monthly.
let's say somebody is doing wonderfully,
Yeah.
and they've been on it. Let's say you can do whatever you want, and it's at least 6 months.
Yeah.
But you're allowed to keep going, and they're in the group that has very few hives. Then that's what I would do.
Yeah.
I wouldn't. The way I would taper, I prefer rather than changing the dose, decreasing the frequency. Instead of 4 weeks, make it 5 weeks, then 6 weeks. I think if you get past 8 weeks, you might have a winner, and then you could try stopping it.
Right.
So I would do that if you have have enough drug to sustain over that period of time.
Okay. Thank you, Alan, very much.
Back and
I was thinking of the patient with CVAD.
Yeah. Yeah, that one's really interesting. Thinking of the Charleston, I think I have a series of like 8 patients.
I just got my laptop.
That's good.
Yeah, sure.
Enlightening.
Thank you very much,
Oh,
Alan.
yeah, good to see you, Mel. Yeah. I'll see you at the Academy meeting, maybe in Orlando.
Yep. Yeah, Orlando, yeah, I guess. We'll know.
Yeah. When we did something.
Let me regroup here. Things are heating up on new space at UWMC, and they pitched me now to have a new temporary space out there. Or room. So the thing about
Oh, you are.
Are you headed out now, or?
I don't know what we're doing. Oh, there's no rush now. I have to go back to the pick up my luggage, and there's no rush. My plane's at 12:20.
Oh, okay, yeah, you got it.
So maybe we'll get a call, something like that, and they get the luggage. I need to be at the airport by 11. It wasn't out by 8 o'clock.
Yeah, we're just half an hour away from the airport here.
Yeah, so it's easy.
UWMC Mont Lake and UWMC Northgate Lake. There's the ER at it's not she just
Yeah. Yeah. Well, I don't want any.
but it'd be a 911 and then I guess you would think in the long term it would be ER it was MySpace. The first thing she was throwing out there was crazy fights for space. She's talking about moving this to rehab.
We were going to send one.
How many, and she told me they're fun.
Up on 4 South. Have you seen their space?
I haven't seen it. She told me she wasn't sure what it was for.
Yeah, she's big on the details of all this. And then she was pitching diabetes.
Like, I think our medical.
Yeah, she told me that was a more long term. Like, that would be.
Like, yeah, and now they all.
Rehab.
Yeah.
Yeah, I think there's a set, there's an office, there's a clinician space, and then there's an additional.
Right. But if you enter the wings of rehab, nurse manager, there's the actual.
Controlled by them.
Yes. Which seems insane. We have no interaction at rehab. This whole thing's so bizarre. Oh, really? I hadn't heard that. So when we have instant regrouping on all this, I don't know what we can meet this week.
Like, I was looking at
What we're going to do in the short term, my time with asthma,
and I feel like there's a lot of pressure to look at it, looking at what we do while we're there and stuff. We work the whole time. extra scrutiny because you guys are missing the sales. Yeah, I know.
the other day, you have it out for a month.